Good evening, everyone. Am I audible? Okay. So myself, Dr. Kavitha. I'm an assistant professor working in JJ Medical College, Davangere. As we already mentioned, the topic for today will be must-knows and frequently asked questions in otology during a viva or external examination. So before the class starts, I would like to convey a few messages. The first thing is, as you know, most of the time, the long cases in ENT and head and neck will be either chronic otitis media squamosal variety for MS candidates, or it could be a head and neck case. And for most of the diploma cases, they'll give even chronic otitis media mucosal variety. So what I want you people to know is, before you go on to the actual preparation for the exam, you should know what are the cases you will be expecting in the exam, isn't it? So for that, first thing is, as I mentioned, chronic otitis media, mucosal variety and squamosal variety should be thoroughly understood. And secondly, few of the centers even keep facial nerve palsy as one of the short cases also. So better we know few topics related to these two, and we will start the class now. As you know, chronic otitis media is described as a permanent disability affecting either pars tensa or pars flaccida. Most of them say it could be a sequelae of otitis media with effusion or acute otitis media where the patient has succumbed to it during his childhood, or it could be just a sequelae of a eustachian tube dysfunction. So the facial nerve palsy, in the exam, the cases given to you will be made to examine as a short case. So you should be able to diagnose the case and examination and present it to the examiner as a short case, the findings. Only the findings will be asked. So these are the commonly kept cases as far as otology is concerned. So how do you start? As you start taking the history and present to the examiner, the few principles you should keep in mind. That is the chronology. As you get the symptom as the first symptom, or the symptom it started first should be put as a first symptom. Don't go by the patient symptom that the symptoms of ear discharge started 1 week back and put it as a chief complaint of ear discharge coming from 1 week. That will be a wrong part from your part, because if you keep the history of ear discharge for 1 week and in the final you say it is a case of chronic otitis media, then you will be making a big blunder. So keep that as history of ear discharge if it is started since childhood. So present as history of ear discharge from whichever side is started from childhood. Okay. Just a minute. There is a technical error here. Okay. Then most of the chronic otitis media, the chief complaint should be either of the ear discharge or the hearing loss. So these will be kept as a chief complaint. Okay. So don't go on adding all the complaints. The patient will be telling to you as the chief complaints. And the moment you ask the history, you should ask about the onset and the duration of the symptom. So if the symptom started during childhood, so start mentioning patient was apparently well, and then the patient developed ear discharge left or right side during his childhood, and then how was the progression, whether the symptoms were happening intermittently or it was a continuous entity. Then the progression of the condition, whether the patient was relieved after a treatment or he is continued to have the ear discharge or the hearing loss even after treatment. Okay, so the order of the presentation of all the chief complaints in your history of presenting illness should be including this: the onset, the duration, and the progression. As far as the discharge is concerned, as well as the hearing loss is concerned, you should be including aggravating and relieving factors without fail. That is, most of the mucosal conditions, the patient will tell you the symptoms of ear discharge will aggravate during the episodes of water entry or during the episodes of upper respiratory tract infection. So that must be added. And relieving factors, that is use of topical antibiotic drops or oral medication should be told. Okay. Then comes the relevant negative history, that is the symptoms like tinnitus, vertigo and hearing loss should be added if you are taking a case of chronic otitis media. So patient would have already told you he has ear discharge as well as reduced hearing. Then the remaining three, tinnitus, vertigo as well as the otalgia should be asked and ruled out. Don't forget it. Then the other negative history including symptoms related to the nose and nasopharynx and the oral cavity and throat, because they have got an important role to play if the patient has chronic adenoiditis or adenotonsillitis or chronic rhinosinusitis. If you don't ask or if you don't mention that in your history, your management will be difficult because you cannot treat the chronic otitis media alone as a single entity. Then comes your past personal and family history. The past history, remember, you will not be adding the history of childhood otorrhea in the past history. As I mentioned, it should be coming in the chief complaint. So what should be added in the past history in relation to the chronic otitis media? That is, history of any childhood exanthematous fever. They have got an important role. Exanthematous fevers like measles or chickenpox, the patient will go for developing something called as necrotizing otitis media, which will leave behind with large central perforation, which will further make the patient to go for developing chronic otitis media. Okay. So that is one of the important thing you should be asking the past history, as well as any past medical history or past surgical history in relation to the ear. That means any history of any complications in the childhood because of the chronic otitis media, patient has undergone any medical or surgical line of treatment should be asked. And thirdly, in the past history, you should be adding the comorbidities, okay, which will have any impact on the patient's treatment course. And personal and family history, as it is to be taken like any other lung case. Then comes history of ear discharge should be slightly elaborated, because just by giving a detailed history of the discharge, you can explain to the examiner why are you telling whether it is a mucosal disease or it is a squamosal disease. That means if the patient is having history of ear discharge which is happening intermittently and patient is having a profuse otorrhea. So how will you explain kind of intermittent discharge happening in mucosal disease? As all of us know, the main pathology in the mucosal variety is there is a permanent defect in the tympanic membrane in the pars tensa. So this perforation makes the patient susceptible to develop otorrhea whenever there is a URTI or water entry, which activates the goblet cells in the mid-layer mucosa, which makes the discharge more profuse. That's how it is intermittent and profuse. Then mucopurulent, as I mentioned, it is because it is produced by the goblet cell with the superadded bacterial infection becomes, it is purulent. So mucopurulent. Then odorless, obviously it is not acted upon by any gram-negative organism. I will be mentioning why it is odor, foul smelling in squamosal later, then you will understand better. And again, it will be not blood stain. And aggravating factors will be because of the URTI or any water entry or because of the allergens. Then relieved by topical medication has got very big impact. That is, remember, the topical antibiotics have got a role to play in mucosal variety, and that is one of the main line of medical treatment. Coming to the squamosal variety, the discharge is more or less continuous when you ask the patient. That means the defect or the pathology in squamosal disease is mainly the pars tensa posterior superior quadrant or pars flaccida retraction pocket, which makes the retraction pocket more and more, as the retraction pocket becomes more and more deeper, at one point of time the neck of the retraction pocket becomes such a way that it cannot drain out the keratin debris outside. So at that point the discharge is continuous, and that at that point you can imagine that it has got no role to play with the association like URTI or water entry, because the retraction pocket and the collection of keratin debris will continue to happen whether there is URTI or not. So that is the reason the discharge is continuous. And how do you quantify in squamosal disease? It is scanty. That means as there is no connection with the mid-layer mucosa, as the mid-layer mucosa or the goblet cells are not the actual cause for the discharge, it is scanty. So the discharge is produced by the keratin debris acted upon by the bacteria, which makes it scanty. So the patient will say only when he clears the ear with the help of the earbud, only then that is the time he will be able to find out there is a discharge. So it will not come out or it will not pour out of the external artery meatus. And purulence obviously because it is only by the external ear. It is not including the mucosal or the goblet cells coming from the middle. So most of the time it will be purulent discharge. And the important factor is the foul smelling discharge in the squamosal variety. It's mainly because of some gram-negative and some anaerobic bacteria. The most importantly, the Proteus as well as the Pseudomonas. So the Pseudomonas usually causes fishy odor to the discharge. And often blood stain is squamosal. Why? Because the activity or the squamosal disease which makes the condition to cause osteitis, which finally leads to formation of granulations. These granulations will easily bleed on touch or easily bleed on manipulation. So the discharge becomes blood stain even with minor manipulation. And as the squamosal variety, there is no connection with the mid-layer mucosa, only the pathology is in the retraction pocket. There is no aggravating or most of the time there is no even relieving factor also. Then coming to the next complaint, that is, okay, this is just a brief summary what I just told. The foul smelling discharge is mainly because of the Pseudomonas and certain group of Proteus mirabilis, Escherichia coli and certain anaerobic streptococci. And blood stain discharge, remember, it is because of the chronic osteitis and the granulation tissue which are polypoidal and easy to bleed. So as you mentioned, the ear discharge is blood stain. The examiner will straightly ask you what are the other causes of blood stained ear discharge. So you should be coming with the causes from the external ear, causes which are because of the mid ear, or even some malignant causes. So from the external ear, the causes could be certain infective conditions like furuncle or otitis externa, or could be foreign body induced trauma, or certain conditions of the tympanic membrane, that is bullous meningitis. When it ruptures, it bleeds. Then traumatic perforation, the history will be very clear in that case. And suppurative otitis media, either it could be acute or squamosal variety of chronic variety. These are all the causes commonly expected. And certain rare causes you should say, that is mid-layer tumors because of the glomus tumors, and rarely, very rarely you should also include possibility of malignancy. So as you complete your history of ear discharge, then you will go on to the history of hearing loss. In that you will be including first the patient's history of onset and progression of the hearing loss, and don't forget to include the impact of the hearing loss on patient's day-to-day activity. So that should be one of the factor you should be adding. And lately you can also expect the examiner asking you what are the causes of fluctuating hearing loss. So remember, the commonest condition where you get fluctuating hearing loss is impacted wax and otitis media with diffusion. And certain patients who develop URTI going for eustachian tube dysfunction also will tell us they have fluctuating hearing loss. And even the Meniere's disease patients, because of the otitic the involvement of the endolymphatic hydrops, the patient will also develop fluctuating loss frequently. Then coming to the complaints of negative history, what I was mentioning in the beginning. So negative history has an important role. As you start mentioning certain negative history, you should be ready to tell the examiner why are you asking this negative history and why are you ruling out. So first and foremost will be the otalgia. So most of the chronic otitis media patient will be having no complaints of any pain in the ear. So if you get a patient who says there is an increase in otalgia, so that the moment you should start expecting any impending complications. Then comes the fever. It mentions any intracranial complication, or it is a suspicion of developing mastoid abscess, so you should be careful of it. Then if you find there is a change in the character of the ear discharge, that is the discharge which was responding or to your treatment suddenly starts increasing in its quantity, that says that there is a reservoir sign or the mastoid is going to develop an abscess. So increase in the quantity of the discharge. Then comes ruling out headache and neck rigidity. That straight away tells that there is a possibility of intracranial complication, the most common one being the meningitis. Then when you say there is no history of giddiness, the reason behind this is any involvement of the inner ear. Then comes the facial nerve palsy. The facial nerve should not be forgotten when you're presenting the ear case. So include the facial nerve as one of the negative history. Then comes the visual disturbance. The importance of visual disturbance lies in that any complaints of deep-seated retroorbital pain with diplopia straight away tells us that is an involvement of petrous apex causing petrositis. So there is a triad. I hope all of you know that that is a Grady-Nico syndrome. In that there will be deep-seated orbital pain because of the fifth nerve involvement, and there is a lateral rectus palsy because of the cranial nerve 6 palsy, and lastly the continuous otorrhea. So why this triad happens? Because of the involvement of the petrous apex in the form of petrous apicitis. There is something called Dorello's canal that which connects the petrous apex to the posterior clinoid process. There is a Dorello canal through which passes our sixth nerve or the abducens nerve. So that is also involved. So together they lead to Grady-Nico syndrome. Then once we finish this negative history, we also finish our chief complaint or the history of presenting illness. Then we'll move on to the past history. So in that, as I mentioned, history of exanthematous fever in childhood is should be asked and ruled out. Then trauma to the ear. Most of the time, if there is a trauma in childhood, that will lead to perforation of the tympanic membrane. If it is large, then you can expect it is going for non-healing developing chronic otitis media at later date. Then head injury again. Head injury will lead to any fracture of the temporal bone, or it can lead to facial nerve palsy. It can lead to various ossicular dysfunction. So the patient will again tell you this history so that you can correlate why there is a hearing loss along with chronic otitis media. Then history of noise exposure and ototoxicity tells that it is because of the involvement of inner ear the patient is developing the hearing loss. Then coming to the systemic illness, the importance of systemic illness lies in that the treatment factor when you are treating a patient of chronic otitis media who also has a diabetes or any medical illness which has an impact on otitis media, that should be treated simultaneously. Okay, once we finish the history, then we'll move on to the examination. So in examination in ENT, before we start the ENT examination, we'll be doing general physical examination. So in that, what are the points you should be keeping in mind? First and foremost, after you examine the patient, look for his vitals and check his temperature, his pulse rate, as well as look for anemia. These are the few important things you should look for as well as you should rule it out. A fever in tachycardia will tell us that patient probably is going for impending complication. Severe anemia tells out that there is a possibility of lateral sinus thrombophlebitis. So at the moment you say there is anemia, the patient, the examiner might ask you what are the two main conditions you can expect in ENT relation severe anemia in the patient. You should say first thing is lateral sinus thrombophlebitis. The second ENT condition where you can expect a patient to be having anemia is hypopharyngeal malignancy. So these two things keep in mind. Then you can also look for and rule out any stupor or incoherent speech in the patient. So that straight away tells us that there is involvement of intracranial involvement. Once we do this examination, then we'll go on to ENT and head and neck examination. So we'll start with the examination of the ear. In that, we will look for the preauricular region, pinna and postauricular region as inspection. So the moment you say preauricular region normal and the position of the pinna normal, they might ask you what can go wrong with the position of the pinna. So the two common conditions what we encounter, that is furunculosis or otitis externa, the pinna will be pushed forwards and outwards. Remember, similar condition which mimics, that is mastoiditis. In that the pinna will be forwards and downwards. So remember, if the pinna is pushed forwards and downwards, don't forget to rule out mastoiditis. So this you will be doing it on inspection. Once you inspect the pinna, then go and look into the postauricular region. So what we'll be seeing, we look for redness, swelling or fullness of the postauricular region, edema. So if there is edema and then fullness, that you can expect there is mastoiditis going to develop shortly the mastoid abscess. Okay. Then the discharging sinus. If the mastoiditis is not treated on time, it can go for hyperemic decalcification and pus can get collected under the periosteum and at one point of time they start discharging. So they develop postauricular fistula. Then operated scare, that is also very important. If the patient is already operated upon because of this COM, and again develop the ear discharge. The importance is that you should be ready to expect some abnormality in the anatomy, because anatomy would have been deranged by the previous surgery. So it will be slightly a difficult approach. So you might need to take the help of your senior colleague to address such case, or you need to have certain advanced management. That is, you may need to go for HRCT of the temporal bone. So these are the points you should imagine. You should be prepared once you see a operative scar behind. Then obliteration of the postauricular sulcus. That is the fullness of the postauricular sulcus. Again, tells us that is a going for postauricular abscess or mastoid abscess. Then local rise of temperature and tenderness over the mastoid region tells us again there is a possibility of mastoid abscess shortly. So better take the patient and go for IND if there is already a developed fluctuation. So the moment you say there is no postauricular sulcus obliteration, they'll ask you what are the differential diagnosis. That is subperiosteal abscess and furunculosis the external canal, which are going for developing spreading cellulitis. So in both the condition, there will be postauricular sulcus. So that is the time you should rule out. So how will you differentiate if there is a postauricular fullness because of the abscess, because of mastoiditis, or because of the furunculosis? So in furunculosis, there won't be any history of URTI, and when you examine that, there will be tracheal tenderness positive. When you put the otoscope, you will find the furuncle in the external canal, and the TM will be definitely intact. Okay, so these are the points which tell you that because of the furunculosis, there is a postauricular sulcus, unlike the postauricular abscess by the mastoiditis. Then after you inspect the preauricular region, pinna and postauricular region, then you will go for eliciting the mastoid tenderness and tracheal tenderness. So what is about mastoid tenderness? So there is a test called 3-finger test we will be doing. That is one finger at the cymba concha, at another at the root of zygoma, and the third at the tip of mastoid. So cymba concha, if it is tender, that tells us that there is a mastoiditis. So patient will be having mastoid abscess. So that is about cymba concha, and root of zygoma tells that the the zygomatic tip, the root of zygoma, those cells are affected, and tip of mastoid, tip cells are affected. Then coming to the posterior superior meatal wall sagging. So after you examine the mastoid tenderness, then you slowly start examining the external canal. In that, if you come across posterior superior meatal wall sagging, then what is the cause? That means there is acute mastoiditis. So there is a periosteal thickening or periosteal involvement which separates the mastoid cavity from the external canal. So that bony partition is involved. So automatically it's an indirect sign, tells us there is an acute mastoiditis set in. So once you finished examining the external canal, then go about the examination of the tympanic membrane. Remember, don't tell the finding of some tympanic membrane at one go. You have to divide it in two heads. That is, finding on the pars tensa and finding of the pars flaccida. So what about pars tensa? First thing is just look whether it is intact or perforated. If it is perforated, start describing the perforation under following heads. That is, whether it is a single perforation, whether it is a small perforation, whether it is a central perforation. So when we have a perforation in the tympanic membrane, you will be having various varieties depending on the size and then depending on the involvement of the quadrant. So if it is involving only one quadrant, then you call it as a small perforation. And if it is surrounded all over by the remnant of the pars tensa, then you call it as a central perforation. So the first diagram is telling us there is a small central perforation because it is involving only one quadrant, that is antero-superior. Then as you see here, it is involving more than one, that is it's involving at least two quadrants. Then that is the time you call it as medium size. Remember, it is central because it is surrounded by the pars tensa all around. You can see there is a difference. That is, in medium size perforation, it is involving only two, whereas if it is involving all the quadrants, then you call it as subtotal. Remember to look for the annulus all around. If the annulus is destroyed, then you call it as a total perforation. And this particular variety is quite dangerous because there is a possibility of squamosal epithelial invasion in this variety. So that's about the central perforation. Then coming to another variety, that is marginal perforation, where one of the margin of the perforation is made by the annulus. The remaining are by the remnant of tympanic membrane, whereas one of the margin is formed by the annulus, because this variety it is quite dangerous because again this has a risk of squamous epithelial invasion into the midlayer. So that's about the central and marginal perforation. Then coming to the, if the perforation, if the pars tensa or pars flaccida is intact, but there is a retraction. So don't straight away say there is a retraction of pars tensa. So the examiner will ask you, why did you say there is a retraction of pars tensa? So you should say certain points. After that only you will be able to diagnose whether there is a retraction or not. So what are they? First thing is distortion of the cone of light, which is one of the finding in the normal tympanic membrane. If the cone of light is distorted, that gives us a clue that there is a retraction happening. Then prominence of lateral process of malleus. It's also one of the earliest signs. Then comes the foreshortening of the handle of malleus. That means the handle of malleus appear foreshortened because of the full tympanic membrane. Then prominent fibrous annulus. If the pars tensa is retracted, then the fibrous annulus stands out. Then because of the chronic inflammation, there will be thinning or dimeric tympanic membrane. And then if the tympanic membrane is too retracted, then it will go and adhere onto the promontory. So these are all various signs depending on which you should say there is a retraction of the pars tensa. Is it enough if we just say there is a retraction of the pars tensa? No. We have got certain grading of pars tensa retraction, which is called SAID's classification of pars tensa retraction. So in the first grade, if you see here, the pars tensa appears kind of retracted, but it is not touching any of the ossicles. It's just there will be impaired, or you can say distorted cone of light. When it becomes grade 2, you can see the pars tensa is going and touching the long process of the incus. In few cases, it can also go on touch the stapes. That's the time you call it as grade 2. In grade 3, what happens is pars tensa goes and touches the promontory. Okay. So but the only differentiation between the grade 3 and grade 4 is in grade 3, on maneuvering, on Valsalva maneuver, on sigillization, you can elicit the movement of the tympanic membrane. Whereas in grade 4, the entire pars tensa is draped onto the promontory. So even after sigillization, there won't be any movement of the pars tensa. That is the time you call it as grade 4 retraction, or you can also call it as adhesive otitis media. So coming to the pars flaccida, if it is intact, say it is normal and intact. If you find there is a retraction of pars flaccida, then you have to grade according to the TOS grading of pars flaccida retraction. So what are they? The grade 1. See, this is the region of, this is the handle of malleus, this is the lateral process, then this is the head of the malleus. So this is the region of neck. So you can see this is the outer attic wall, or the scutum what we call, and this is the region of the pars flaccida. So in type 0, that is normal, and type 1, there is a dimpling of the pars flaccida without any further damage to the outer attic wall. Whereas in type 2, what happens is the retraction of the pars flaccida is so much that it goes and adheres to the neck of the malleus. But the entire retraction pocket, you can see entire retraction pocket without any hidden areas. Whereas in type 3, there will be some hidden area of the retraction pocket which will be not seen clearly by direct examination, as well as there will be minimal damage, or you can say minimal sputal erosion, because in the type 3. And type 4 is variety where the retraction pocket is so much that you can't see most of the retraction pocket, which is hidden, and the sputum will be slightly more eroded, or you can make out that is definite erosion of the the sputum. So that is the type 4. So whenever you have a retraction, you should grade according to this grading system and mention whether there is any hidden fundus and whether there is any cholesteatoma debris or chacoid debris, you can describe it. Okay, that's what I just mentioned now. Just to briefly recap your memory about pars flaccida, if you are asked what is pars flaccida, you mentioned it is the superior part of the tympanic membrane, which is above the level of malleolar folds, extending up to the outer attic wall. Other name for outer attic wall is scutum. Okay. Then it forms the lateral wall of the epitympanum. That is the actual definition you should give. Then if we are asked what is the reason we are calling it as pars flaccida, you should be telling that majority of the books say that there is a lack of fibrous layer of tympanic membrane in pars flaccida, and few books even mention that the pars flaccida has got haphazardly arranged or loosely arranged fibrous layer in its middle layer. So that is one of the commonly mentioned reason in most of the books. That's why it is flaccid. Then you should also remember certain relation, that is the ratio between the pars tensa and pars flaccida. So pars flaccida is around 1 and pars tensa is around 6. That is 1:6 ratio of flaccida to tensa. Then if you get a case where there is a debris, or you can say there is a debris mixed with the wax in the attic region, you should be suspicious of cholesteatoma. That means you cannot reach the debris in the attic region. It gives a clues to us, that is it could be, most of the time could be, it could be a cholesteatoma. Okay. Then coming to the further examination, once you mention your finding on tympanic membrane, and you will be doing something called mobility. You will be checking for the mobility. After you see the mobility, you will be mentioning whether the tympanic membrane is mobile or not. Then you will be asked, how did you check for the mobility? So that there are certain clinically available maneuvers to check the mobility, that is Valsalva maneuver or Toynbee maneuver. So these are the commonly done maneuvers. And if you are having certain instrument, you can check the mobility with that also, that is Siegel's pneumatic speculum. So if you know something about this Siegel speculum, it is good. So it is kind of a lens, which is a convex lens with the ear speculum attached to it and a tubing which connects to a bulb. So with applying pressure to this bulb, you can deliver this pressure along the tubing, and it can be transmitted along to the speculum to the ear. So this is one of the maneuver to check for the mobility. Okay. Then other advantage, the moment you say Siegelization, they'll ask you what are the other uses of Siegel's pneumatic speculum. First thing is, once you check the mobility, you will be able to differentiate whether the tympanic membrane is adhesive or it's only atelectic. Atelectic membrane will move with Siegelization, whereas adhesive TM will not move with Siegelization. The other advantage is it gives us slightly magnified view, that is around 2.5 times more magnified. Then the other rare uses, that is use of insufflation of medication. Certain powder form of medication or even topical drops can be delivered to the middle ear in a better manner after with the help of the Siegel's pneumatic speculum. And lastly, you can also carry out something called Fistula Test with the help of Siegel's pneumatic speculum, because when you apply pressure and release, there will be a change of pressure you are transmitting through the external aortic canal to the inner ear with the help of the Siegel's speculum. So you should know these uses of Siegel's speculum. So once you check the mobility, then the next step of examination will be tuning fork test. The moment you say tuning fork test, you should be knowing what are the principles and what is the inference of the test. The first and foremost, you will be doing a test called Rinne's test. First, always remember you are supposed to carry 3 sets of tuning fork, that is 256 Hz, 512 Hz and 1024 Hz. But always remember, the moment you start carrying out Rinne's test, always start with the 512 Hz, and then depending on the interpretation of 512 Hz, you will be either step down to 256 Hz or 1024 Hz. Okay. Why? Because the 512 Hz tuning fork has got few advantages. That means it falls in the speech frequency range. The speech frequency will be again 500 Hz to 2 kilohertz. That is the range with which we speak. So 512 Hz falls well within the speech frequency. Then tone decay is less with 512 Hz and overtones also less. So these are the advantages. Why are we using 512 Hz? Okay, so once you do Rinne's test with 512 Hz, you will compare the air conduction with the bone conduction of the tested ear. In that, if the patient says air conduction was better than bone conduction, that is Rinne's positive. So you can infer whether it's a normal hearing ear or the patient has hearing loss in that ear. The inference is that is a sensory neural hearing loss. Then the bone conduction becoming better than the air conduction, then you call it as Rinne negative, and you can get it in patient with conductive deafness or in case of mixed hearing loss. Rinne equivocal. So what is Rinne equivocal means to you? That means air conduction as well as bone conduction was of the same duration. That means it was same, and you can get it in patient with mild conductive deafness. Then there is an entity you should remember, it's called false negative Rinne. That is the patient, the particular ear which is being tested, if it has severe unilateral SNHL, then the tuning for what you're keeping out to the mastoid to test his bone conduction will trace over, and because of the transmitted sound through the opposite ear, the patient will be telling negative. So that's the reason you should remember, in case of severe unilateral sensorineural SNHL, there are possibility of getting false negative Rene. Then, as I was telling you, once you do the Rene test with 512 Hertz, if the Rene becomes negative, then you should step up to 1024 Hertz and do the Rene test again. If the Rene comes positive with the 512 Hertz, then step down to 256 Hertz and do Rene again. Okay. So, if you get a patient who has hearing loss and Rene comes negative with 512 Hertz, at least the patient will be having moderate conductive loss of around 25 to 40 decibel. Then do 1024 Hertz again, and Rines comes negative, that means he has a severe conductive hearing loss. So the advantage of Rines test, apart from knowing what type of hearing loss, you can quantify the hearing loss also. So Rines 256 negative and 512 and 1024 positive is mild. Okay, that's how you should be concluding at the end of the Rines test. Then comes the Weber's test. It's purely a bone conduction test, and it is useful if there is a unilateral deafness or the cases where there is a significant difference between the difference in hearing between the two ears. So if the patient says central, that means there could be a normal hearing, or in patient with bilateral equal deafness. So bilateral COM telling Weber being central, that means the hearing loss in both the ears are equal. And if you get a patient who has Rines positive for all the three frequencies and Weber is getting lateralized to one of the side, that means the affected ear or the conductively deaf ear has a hearing loss of at least 5 to 7 decibel. So that way Weber is quite sensitive test. The other question you can expect with the Weber's test is why the Weber gets lateralized to the conductively deaf ear. So all of you should remember the fact that when are we testing the Weber's test, both the ear will be receiving the sound equally. But the ear which has conductive deafness is not getting any sound or the ambient noise of the environment because the conductive apparatus is at fault. So only the transmitted sound because of the tuning fork will be heard better. So that is the reason the Weber's test becomes positive or lateralized to the conductively deaf ear. That is the reason. Then the third tuning fork test you should know is the absolute bone conduction test. It is purely again a test of cochlear reserve or the bone conduction of the patient will be tested. So here interpretation should be either as reduced or same as examiner. You cannot say it is normal because always it is tested with the examiner. So with respect to the examiner, whether it is reduced or same as examiner, that should be the interpretation. So this is just a brief recap of tuning fork test. Rines test is a Rines test you can interpret if there is a difference of at least 15 decibel between the air conduction and bone conduction for it to be significant. If it is the difference between air-bone gap, if it is less than 15, then Rines cannot be used as a appropriate test. And Weber's test is even quite sensitive test. Even the decibel of 5 decibel loss also can be picked up with the Weber's test. Then degree of hearing loss that already I mentioned. That's how we should interpret. Then after you do that tuning fork test, then you'll be doing certain other tests. That is examination of the vestibular system, then examination of the facial nerve. In the examination of vestibular system, you will be doing some test called Fistula Test. That is by intermittently changing the pressure of the extra-aortic canal and transporting this pressure to the inner ear. If the patient is developing any nystagmus or he complains of any giddiness, you will be looking at. So if the fistula test is carried out and the patient says he is developing giddiness and you are eliciting a nystagmus, that is the time you call it as positive fistula test. And after doing this variation of pressure, if there is no response, then you call it as a negative response. Then two things what you should remember for the exam is false positive and false negative Rene. What do you mean by false positive test? There is a fistula test coming positive, but it is not associated with any fistula. That means if there is a congenital syphilis or venous disease, there will be fistula test positive, but obviously there won't be any fistula. That is the time where you get false positive. That's also called as Hennebert sign. And false negative fistula test means you are eliciting the fistula test. There is a fistula, but the patient is not having any giddiness, or you are not able to elicit any nystagmus. That means the fistula is bridged by something. That is, it could be a polystritum which is bridging over the fistula, and the test becomes negative, or the disease has eaten up complete labyrinth, causing dead labyrinth. So labyrinth is not able to elicit any nystagmus. So that's the reason it becomes false negative. That's about fistula test. Then I mentioned facial examination. The moment you say facial examination normal, you will be asked why are you examining the facial limb. All of you know the facial limb has got a long course in the temporal bone around 30 millimeters in the fallopian canal. So it has got a lot of importance, as well as surgical treatment also. When you're operating for chronic otitis media, facial nerve should be respected properly. Okay. So then comes examination of the other system, that is examination of nose and throat, to rule out any presence of factors which affect final outcome of the treatment. If you don't treat the pathology in the nose, nasopharynx or oropharynx, and if you just treat the ear, there is a possibility of recurrence or treatment failure. So you have to treat this condition before you attempt to treat the ear. And comes the examination of the neck. What is the importance of examination of neck in relation to the ear? Okay, so first thing is, whenever you're having a patient of chronic otitis media and you are suspecting any impending complication like a neck abscess. So basalt abscess, one of the complications of acute otitis media. So examination of neck has a role. Then presence of neck rigidity, that is neck rigidity because of the meningitis secondary to the ear cause or the chronic otitis media. So you have to examine the neck. Then examination over the internal jugular vein to rule out any tenderness. That says if there is a tenderness, that says that there is a possibility of active sinus thrombophlebitis. So these are the various reasons you will be examining the neck in a case of chronic otitis media. So after you finish all your examination, you will be proceeding on to the diagnosis. In that, you will be mentioning chronic otitis media. So you will be wondering why I'm not telling chronic suppurative otitis media. If you go by the latest literature, the cause for chronic otitis media is not always secondary to a collection of the pus. So it could be just a eustachian tube dysfunction which has led to chronic otitis media. So earlier it was told that it is chronic suppurative otitis media. Nowadays the nomenclature has changed. We will be calling it as chronic otitis media, whichever ear, left or right ear or bilateral. Then the variety of chronic otitis media, whether it's a mucosal variety or squamosal variety. Then mention whether it's an active stage or it is an inactive stage. If the ear is presently discharging when you are examining, you call it as active in case of mucosal disease. And when you are examining a squamosal disease, there is a corrected keratin debris which is visible to you, then again it is called as squamosal active. Okay. Then comes the comment on the hearing loss, whether the patient has hearing loss. Describe the kind of hearing loss, whether it is a conductive deafness or it's SNHL or it's a mixed. Then describe about the severity of the loss depending on your tuning fork test. After that, you will be mentioning the presence or absence of any impending complication. If you have elicited any of the signs which suggest that there is an impending complication, you should comment possibility of involvement of the facial nerve or involvement of the mastoid. That should be included. If nothing of that sort exists, you should say no impending complication. Lastly, don't forget to include the comorbidities. If the patient is suffering from any other illness, you should mention about that particular illness like diabetes or hypertension or bronchial asthma, etc. Then lastly, if there is any presence of any other system like nasal or oral pathology, that should be added, like deviated nasal septum, chronic tonsillitis, chronic adenotonsillitis. That should be at the end. So that completes your professional diagnosis. The moment you complete your diagnosis, you can directly expect, so how will you proceed? So that means the management of the patient should be under two heads, that is investigations and treatment. So among the investigation, they'll ask you what are the specific investigations you would like to do for this patient. So firstly, in the OPD, you will carry out certain things, that is photomicroscopy. What are the advantages of photomicroscopy? First thing is you will be able to get the pus for culture sensitivity, and you will be able to confirm your findings. Whatever you have examined through otoscope will be confirmed by the photomicroscopy. as well as you will be having a better look onto the ossicular status and their presence or absence in the ear, which you couldn't have made out through the otoscopy. And you can also have an idea or the binocular view what you will be expecting in the operation table. So if you have done an automicroscopy in the OPD, it's always better, so that you can prepare for your surgical management. And other than that, as I mentioned, you can take first for culture sensitivity, and depending on that, you can change your treatment or start your treatment. And the other specific investigation you should do is pure tone audiogram. So the moment you say PTA, they'll ask you what are the advantages. First and foremost, you will be able to quantify, as well as you will be able to make out what is the kind of hearing loss, and it acts in document preoperatively to diagnose the kind of hearing loss. It acts as a document, and it's one of the important medico-legal document, because if you have not done the PTA and you operate the patient, and the patient can always say that my hearing was better previously and after surgery my hearing has gone down. So to avoid this medico-legal issue, you can have this as a medico-legal document. These are the various advantages of pure tone audiometry. And the third specific investigation, as of now, for today, most of the surgeons won't prefer X-ray of the mastoids. But for academic point of view or exam point of view, better you know something about the X-ray mastoid. So in that, you can expect certain questions. That is, what is the standard view taken for the mastoid? That is X-ray of the mastoid with Schuller's view. It is a craniocaudal oblique view done for the mastoids. So that is one of the questions you can expect. And what is the appearance of X-ray mastoid? That is, ground glass appearance is the classical appearance of the opacified mastoid you can see in the X-ray. So this slides again tells about the importance of PTA already mentioned, and most of the centers nowadays follow taking a high resolution computed tomography of the temporal bone instead of X-ray mastoid. So if you say HRCT of temporal bone in the exam, you should be able to substantiate. They can ask you, why are you asking for HRCT temporal bone? So most of the cases, if you suspect having some complication, you will ask for HRCT of temporal bone. Okay. The other condition where you ask is in revision cases or previously operated cases, because of the disturbance of the landmarks. You will not be able to have the typical landmarks, so we will look for the landmarks. And the third reason why are we asking for temporal bone CT is when you are having some congenital anomalies. So when such patients are put for surgeries, you better know the landmarks well before the surgery. So these are all the various reasons you should be giving. So in clear-cut cases, when you have good findings otoscopically or automicroscopically, better you need not have CT in all the cases. Okay. So those findings, like what are the findings you can expect in CT temporal bone? Better you know. First and foremost, the earliest sign is the scutal erosion. Okay. So damage to the sputum is one of the earliest sign. Then after doing CT, you will be having certain idea about certain landmarks. That is status of the ossicle, then involvement of the dural and sinus plate, and involvement of the facial nerve. If there is any erosion of the fallopian canal, then you can also look for any labyrinthine fistula. Okay. Then presence of disease in the sinus tympani or facial disease. So if there is a disease in these two areas, these are slightly difficult areas to approach. So the surgeon has to be prepared to operate such cases. Then obviously you can look for the presence of sclerosis in the mastoid and any involvement of the intracranial structure in the form of abscess. Okay. And when you're suspecting lateral sinus thrombosis, there is a halo sign or delta sign, what we call. That is also one of the signs or finding you can look for in CT temporal bone. So once you've done all the investigation, then you will proceed to treatments. What are the questions you can expect in the treatment? So whenever you're having a treatment protocols, your aim should be very clear. So what are the aim of treating a case of COM is to give a safe and to give a dry and to give a hearing or functional ear. These are the three main the aim or the goals of a surgeon: safe, dry, and hearing ear. So depending on these, to reach these aims, what are the surgical approach you take, that differs. So in standard mucosal type of disease, treatment protocol will be either myringoplasty or tympanoplasty with or without mastoidectomy. So the moment you say these words, they will be asking you what are the definitions. So for myringoplasty, it's just a surgical procedure where you are closing the defect of the tympanic membrane without doing anything with the mid-layer. So mid-layer will not be touched, only the closure of the perforation of the tympanic membrane by graft. And tympanoplasty differs in meningeoplasty in certain way. That is, in that you will be exploring the mid-layer cavity, and your intention is to eradicate the disease from the mid-layer, and you will inspect for the ossicular chain, whether it is intact, whether it is mobile or not. Then you will reconstruct the hearing mechanism with or without. Remember, with or without grafting of tympanic membrane. That is the standard definition of the tympanoplasty you should be knowing. Then to do this particular procedure, what are the approaches you can take? So there are three standard approaches. The approaches, what we they regularly follow is postauricular approach by Wild's incision. There are two more approaches you should be knowing. That is endoral approach and permeatal approach. Lempert's endoral approach and Rosen's permeatal approach. These are the two other approaches you can also take to do the ear surgery. So once you're done, once you started the surgery, then the first thing you will be doing is graft harvesting. So when you start telling that I will harvest the graft, then you can expect what are the sites of graft. So certain varieties like autografts are available, which is commonly used is temporalis fascia. And you should be knowing there are certain other things like tracheal perichondrium, vein graft, and fascia lata. So these are all various types of autografts. Then coming to the homograft, that is you can use certain cadaveric lyophilized dura. There are certain dural banks available where they give lyophilized dura and cadaveric tympanic membrane. But because of the risk of prion disease, these grafts or homografts are usually not used. Only the autografts are preferred by most of the surgeons. Then you can expect, why are you using temporalis fascia, why not other? The first thing is you can take the graft or harvest the graft through the same incision. That is the best advantage, the best part of the temporalis fascia. Then availability of the graft, that is you can harvest as much of graft as you want. So that is the second advantage. Then the third being tympanic membrane resembles the fascia, temporalis fascia resembles the tympanic membrane in its thickness as well as the consistency, being having low BMR of that of the tympanic membrane. So that is one of the best part of temporalis fascia. Then it acts as a good scaffold when you place onto the TM. It allows the epithelium of the outside as well as the mucosa from mid-layer side to grow well on its surface. So that is the scaffold property of the temporalis fascia. Then lastly, you should also tell that the temporalis fascia is relatively avascular, so it can withstand ischemia for longer duration. So these are all the various advantages why are we harvesting the temporalis fascia. So once you harvested the fascia, then you have to place the graft, isn't it? So what are the various techniques? So they are onlay as well as underlay grafting methods. What do you mean by onlay grafting? The graft will be placed lateral to the remnant of the tympanic membrane. So the surgeon will lift off the epithelial layer of the tympanic membrane and the graft will be placed on the fibrous layer. So that's how the onlay grafting is done. And underlay grafting is the commonly done procedure wherein the graft will be placed medial to the perforation of the tympanic annulus. So that is one of the easy way compared to the onlay grafting. Onlay grafting requires certain surgical skill. It is also carries the risk of epithelial pearl formation, which is not there in underlay grafting method. So that's why underlay grafting is most preferred method. Once you've done the grafting and once your surgery is complete, then what are the points we'll be expecting as a successful tympanoplasty? Okay, so once your surgery is done, you will be expecting the patient to get a healed TM, or the tympanic membrane defect should heal. So before you get such a good result, that means if you have done a proper workup, only then you can expect the success in your surgery. So what are all the prerequisites you should have done before taking the patient on to the OT? That means the patient should have had a dry ear at least for 6 weeks. 4 to 6 weeks, the patient should have had a dry ear. If you are in a hurry, if you operate the wet ear, the chance of graft failure is very high. Then patient to develop a good hearing gain after the surgery, patient should have a good cochlear reserve. That means the patient should not have sensory neural loss or mixed loss. If he has such hearing loss, then hearing gain after the surgery will not be good. Then functionality of the eustachian tube. If there is a eustachian tube pathology or dysfunction which is not treated, then success of tympanoplasty is not so good. Then if you have treated well the nose and throat condition, again the treatment the surgical failure is less. Okay. So coming to the complications of ear surgery. So once you operated the patient, once you are operated the patient and you get a patient in your follow-up period, if you get these, then that means there was something wrong during your surgery. So what can go wrong? Per-operatively, you can certain problem, and post-operatively, there are certain complications. So what are the commonest on-table complication you can expect? The first and foremost, you should be very careful when you are handling the ossicular chain and avoid damaging the facial nerve, dural plate and sinus plate, which can lead to torrential bleeding. And fistula formation. When you are drilling for the mastectomy, you should be very carefully drilling around the lateral canal. If you drill the canal, there is possibility of lateral canal fistula. Then, if you have a patient who has a high lying jugular bulb, when you are lifting the annulus, when you are entering the middle ear and when you are lifting the annulus, that is the time you can injure the high jugular bulb and you can expect a lot of bleeding happening that time. And injury to the aneurysm of internal carotid artery. It's quite rare. It's not so easy to damage the internal carotid artery unless it has got aneurysm and it is bulging in the anterior-inferior wall of the middle. Then, if you are drilling and causing the injury to the in the inner ear, or there could be damage because of the drill itself. That is, it can cause noise-induced hearing loss because of the drilling, leading to sensorineural hearing loss. Then damage to the chordae tympani. Most of the time, patient will come with change in the taste sensation in the lateral border of the tongue. So these are all the complication you will be doing during the surgery. Then what are the post-op complication you can expect? Most commonly the infection. That is, it could infect. That could be infection of the postoral suture side, or it could be infection of the operated midlayer itself. Then worsening of the deafness, as I told you. It can be because of the graft failure. If the graft is not taken up properly, if it has medialized, or if the perforation is not completely closed, there could be worsening of the deafness, or because of the injury to the inner ear structure, the patient may develop worsening of the hearing. Then the tinnitus and vertigo tells us that we have injured the labyrinth. Then facial palsy. Post-op facial palsy is mostly because of the post-op edema. So most of the time, the edema because of the surgical handling of the nerve will lead to late onset facial palsy. Then taste disturbance, again because of the chordae tympani damage. Then labyrinthitis and cerebrospinal fluid leak, meningitis, encephalitis. These are slightly rarer complications, but you should be cautious about these complications. Then if you're operating on a squamosal disease and the clearance of disease is not done properly, then you can definitely expect recurrence of the polysteatoma at the later date. So after you have a patient who has been treated, operated, everything is done properly, it is fine. But certain conditions, we come across certain patients who have squamosal variety of chronic otitis media, but for some reason he is not able to undergo surgery, whether he could be unwilling for surgery or he could be unfit for surgery. Then what will you do with such patient? So in that time, you should be telling the examiner that you should do a regular OPD visit should be done, and regular oral toileting should be done, and frequently you should put the patient under photomicroscopy, and patient should be asked to use topical antibiotics. This is the only way you can manage the patient. So patient should be encouraged to visit the OPD regularly for oral toileting. So you can, after you finish your discussion of your case per se, then you can have certain additional question. You can say they are kind of a bouncers. What are they? So I'll be telling few of them. First thing is that is something called Warren bleed. When you're doing a mastectomy around the facial canal or the fallopian canal, if you come across certain kind of ooze from the that side, operative side, that says that you're very close to the facial now, so you should be very careful. So that bleeding happens from the vasa vasorum. Okay, so you should better avoid going in close to that area. Then when you're doing a mastectomy, we do something called saucerization of the mastoid cavity. That means you smoothen out the mastoid cavity, avoid all any kind of bony spicules. So why are you doing that? You're basically doing that to help in epithelialization, the helping of skin to grow easily because of the smoothing, and also you will be avoiding something called sump effect. When you do that, when you make the mastoid cavity in line with that of the external canal, you are avoiding the sump effect. So there is possibility of easy drainage of the mastoid cavity without any collection of the any discharge or secretion in the mastoid cavity. So you are avoiding any sump effect, as well as you are helping the epithelialization by saucerization. So that is the advantage of saucerization. Then certain rarely asked questions like, what is the kind of residual hearing loss in types of tympanoplasty? So in type 1 tympanoplasty, there won't be any residual hearing loss. In type 2 tympanoplasty, you are placing the graft onto the incus. So you can expect some residual loss up to 10 decibel. In type 3, as you're placing onto the stapes head, there will be around 10 to 20 decibel of hearing loss. In type 4, we are placing onto the foot plate, you can expect a residual loss at least of 10 to 20 to 25 decibel. And if the stapes foot plate is completely immobile, and if there is a post-op discontinuity following surgery, the hearing loss can be up to 60 decibel. So that is the worst scenario. And in type 5 tympanoplasty, we have done a fenestration, the hearing residual will be around 20 decibel. You should better know this kind of hearing loss you can expect post-operatively. Then there is something called Mary's index. I want people to know, that is something called as mid-ear risk index. So this is a criteria which was used pre-operatively in the patient. If patient has got high index, their index is high, or the number is high, then you can expect failure rate. That means there are certain points or factors in the patient, like otorrhea. If the patient has otorrhea at the time of surgery, then you should give the score as 2. If there is no otorrhea, then score becomes 0. Then depending on the type of perforation, whether it is central, subtotal or total, each central and subtotal and total is given mark of 1. And presence or absence of cholesteatoma. If there is no cholesteatoma, you grade it as 0. If there is a cholesteatoma, and then grade it as 2. Then depending on the integrity of the ossicle, it is graded 0 to 4. Then presence of absence of mid-layer granulation, and history of smoking. If he is a smoker, then give the grade of 2. So once you add up all that, then look for the score. If the score is coming between 1 to 3, then you can expect a graft success rate of up to 86 to 90%. And if the score is high, going towards 7 to 12, then the failure rate you can expect is almost 100%. So it's indirectly one way to look for or assess the success of your surgery, what you are going to do. Then you can also have certain questions by the examiner, that when you're having a patient of chronic otitis media who is asking you, doctor, what will be the hearing benefit I'll be getting after my surgery? So you should be able to give preoperative score, or you can call it as evaluation of hearing benefit in mid-layer surgery by using 2 scoring method. I hope at least you remember the name. There are 2 grading method. One is Glasgow benefit plot. Another is Belfast 15/30 decibel rule of thumb. So these 2 are the 2 methods or 2 techniques used to give preoperative assessment of hearing benefit post surgery, post mid-layer surgery. So these are the 2 methods used. Then you can expect certain questions about facial nerve palsy. So what are all the various causes or the factors which cause facial nerve palsy in a patient on undergoing ear surgery? The commonly encountered condition all of you must be aware of is use of local anesthesia. If you're giving a local anesthesia inadvertently directly onto the facial nerve, you can expect injury to the facial nerve. Then the other conditions being trauma due to the burr. So directly doing burr onto the facial nerve can cause permanent damage to the facial nerves. The commonest site of facial nerve injury during mastoid surgeries, the commonest site being the second genu, where the horizontal segment becomes the vertical segment, and even the vertical portion itself. These 2 are the commonly injured segments. Then various other causes, not the direct effect, but the indirect effect by the heat of the drill bit. Commonly the diamond burr usually releases lot of heat that causes thermal damage to the facial nerve, or even the use of cautery can damage the facial nerve. Then if you're not injured the facial nerve directly in the surgery, but there is a possibility of post-op inflammation which causes the compression and leads to facial paresis at the post-op period. So these are all the various causes of fascial palsy you can expect in ear surgery. Okay, a few things about the myotoplasty and mastoid cavity. You should be knowing at least two names of the myotoplasty, that is Corner's and Siebenmann's type of myotoplasty. So these are the commonly done myotoplasties, and you will be asked how will you assess the adequacy of the myotoplasty what you have done, whether it is adequate or not. So you should say at least double the size of the extra-aortic canal, roughly. So when you are seeing the size of the myotoplasty, it should be at least double of that of the extra-aortic canal, or even roughly index finger of the surgeon should pass easily through that myotoplasty. So these are the two blind technique of making the confirmation of the adequacy of the myotoplasty. Then you may get a question that why are you doing the myotoplasty? Okay, after the mastoidectomy, why are you doing the myotoplasty? So you should be telling that after doing myotoplasty, it is an easy access to look for any disease. Whether it is recurrent disease or a restored disease, you will be able to see directly through the extra-aortic canal if you have done an adequately wide myotoplasty, as well as it helps in drainage of the secretion produced in the mastoid cavity. Okay, so these are the reasons why are we doing the myotoplasty. But there are certain problems you can expect if you have done a very large myotoplasty. That is, one is the poor cosmesis because it looks odd, and you can expect recurrent infection because of the wide raw area, and it can also lead to certain caloric effect to the patient. So if you have done too large myotoplasty, that is also not good for the patient. Then if you say myotoplasty, then next question will be about the mastoid cavity. So what are all the various problems mastoid cavity can lead to? The first thing is patient will come to you repeatedly because of the persistent discharge happening from the ear. So he needs to visit your OPD repeatedly. Then patient has difficulty in wearing hearing aid. So hearing impairment is one of the problem with the cavity. Then patient has to always follow water precautions. So whenever there is a water entry, he may develop giddiness because of the caloric effect. So these are all the various problems the patient with mastoid cavity can have. Then if you have told that these are the problems, then you can expect the question that what are the reasons for the patient to have persistent otorrhea following the mastoid cavity? They are poorly done surgical procedure. Like if the patient has myotoplasty which is very quite narrow, then the drainage will not be easy. So the patient will have collection of the sump effect and there will be chronic otorrhea. Or if the lowering of the facial ridge is not done adequately, if the facial ridge is high, again it creates a problem for the discharge to come out easily. Then persistence of granulations. Because of the cavity, big cavity, there will be raw area, there will be a lot of granulations which keep on discharging regularly. So that is also one of the cause for persistence of discharge. And lastly, but not the least, the residual disease. If the disease is not cleared completely, if there is a cholesteatoma which can also act as a residual disease leading to continuous discharge. To avoid all that, we have got something called mastoid obliteration. So you can decrease the size of the mastoid cavity, what you have done. So you can say the indication to do mastoid obliteration like persistent discharge because of the reconstruction. If you want to make the patient wear the hearing aid, you should obliterate the mastoid cavity. And patient who has mental retardation, who cannot maintain the hygiene of the ear, he can also be made to undergo mastoid obliteration. And patient coming to you with repeated vertigo, to avoid certain occupation like swimmers, you also have to have mastoid cavity which has been obliterated at the first sitting. Then patient who wants to go for water sports also should have mastoid obliteration done at the time of surgery. So how can you do mastoid obliteration? There are various ways to do mastoid obliteration. There are flaps, certain flaps locally available. That is the palvas flap, which is the one which is commonly used. Then comes free muzzle flap, which is done using sternocleidomastoid. Then pedicle muzzle flap can also be done. Then you can use all the drilled segment as bone chips and put it into the mastoid cavity. And musculoperiosteal flap is also one of the way to obliterate the mastoid cavity. At least you should know these names when you're planning for mastoid cavity obliteration. Then you can have a patient who has bilateral mucosal disease, which one which ear you would like to operate first. Okay, so you should, first thing is look for the hearing impairment. The worst ear should be always operated first. Don't touch the better ear. Then the second criteria is keep the patient's ear dry and then operate. In that case, look for the ear which is dry for longer time. So that is the ear which has a high success rate. And if the patient has hearing loss equal on both the sides, then ask the patient the preference for surgery. So that's how you decide the patient has bilaterally symmetrical disease. Okay. Then certain questions about osteoplasty you may be asked is what are the materials you use for osteoplasty? They are like cartilage, autografts, biomaterials, and commonly used being the cartilage. Okay. The advantage of cartilage is it prevents the adhesion. So that is one of the best part of cartilage, and exclusion rate is also very low with the cartilage. But the only drawback is it easily gets absorbed. So that's a drawback of using cartilage. So various materials you should be aware of osteoplasty. So please be prepared about that. And these are, I think all of you must be knowing about the type of mastoid dematization. I don't want to go into detail. Only thing is you should be knowing what are the types of mastoid and the theories behind deficient pneumatization. So most of the books will give you about this. So I'll not go into detail of it. And few questions about mastodectomy you can expect is a canal wall up versus canal wall down procedure. The procedure, at least you should know their names. That is, canal wall up mastodectomy is posterior tympanotomy and combined approach tympanoplasty. These are the two varieties. And the advantage of this is it has normal contour of EAC. It doesn't affect the contour of the external canal, and the mid-layer cavities maintained. The mid-layer will be preserved, and there is no cavity problems, which I mentioned just before. And technically, this procedure is slightly difficult. So that's why most of the surgeons prefers canal wall down procedures. What are these canal wall down procedure? Commonly done inside out procedure is atticotomy, whereas outside in procedure is modified radical and radical mastodectomy. So why do you prefer canal wall down over canal wall up? Is it is easy to do, but there are various other problems like contour of EAC will be affected, the mid layer will not be preserved, there will be shallow mid layer, then cavity problems will be there, and recurrence rate, the recurrence rate is very less. That is the best part of having canal wall down procedures. So then you may be asked, what do you mean by an ideal mastoid cavity? That is the cavity which is well saucerized without any bony specules, and you should have lined the cavity with the graft. The floor of the mastoid cavity should be flushed with that of the floor of external canal, so that you can avoid the sump effect. And facial ridge should be adequately lower, and you should have adequate meatoplasty done to have the easy drainage. And if possible, always try to do primary partial closure to reduce the size of the cavity. And lastly, this is the commonly asked favorite question by the examiner. What do you mean by recidivism? So it's a combination of residual disease with the recurrent disease. So residual cholesteatoma most of the time will be left behind by the surgeon purposefully. So why? Because the cholesteatoma is very close to the vital structure. Like it could be close to the exposed facial nerve. If you try to remove that cholesteatoma, you will be injuring the facial nerve. And if it is close to the labyrinthine fistula, then you better avoid it. Let it be there. You can always do a second surgery and remove it. And if it is again close to the foot plate of stapes, don't try to remove that particular cholesteatoma. So these are the sites where the surgeon will be intentionally leaving behind the cholesteatoma to avoid the complication. So I was mentioning you there are certain nomenclature you should know, that is inside out mastodectomy and outside in mastodectomy. So the outside in mastodectomy is what most of you have seen. That is drilling start from the mastoid cavity side, and then you will be following the cholesteatoma sac towards the mid layer through the additus, attic, and the mid layer. That is the outside in technique. But the disadvantage of this technique is it gives us very large cavity. So if you have a patient who has a limited disease in the attic, the method what you follow is inside out technique, where you will start the drilling from the attic region, then at additus, and then you'll go to the antrum. Here you will be following the disease from mid-layer side to the mastoid side. So obviously you can expect a small mastoid cavity which is free from all the cavity problems. So inside out technique is better for the patient. Only thing is it has got slightly technical skills should be required to carry out the inside out technique. Okay. Then already I mentioned there's just a few additional points. Why will you expect retraction in the posterior superior quadrant? So the reasons behind this is the posterior superior quadrant of the middle is slightly least ventilated area. So easily the retraction develops here. And fibers in the fibrous layer of the tympanic membrane is haphazardly or loosely arranged so that it goes for retraction. Then ossicles here has got crowding. That is, lot of ossicles sit there in the posterior superior quadrant. So ventilation will be again affected. And the mucosa which lies here in the posterior superior region absorbs lot of air because it is cuboidal epithelium. And mucosal folds also are there in the posterior superior region, which makes the ventilation slightly inaccessible, making the posterior superior quadrant easy for retraction pockets. As I'm mentioning you about recidivism, so cholesteatoma residuum may be either from the residual disease or recurrent disease. So there is no clear-cut guideline. How will you differentiate residual disease from recurrent disease? So most of the surgeons go by the method that if you find a patient on follow-up within 6 months of period, if the cholesteatoma appears, then you call it as residual disease. And if the cholesteatoma appears in the year after 6 months of surgery, then you have to call it as recurrent disease. So the reason for residual disease is incomplete removal during the initial or the primary surgery. So that's why the residual disease is present. Whereas the recurrence happens most of the time after the complete surgical removal because of the new pathological process. So that's how clinically you will differentiate whether it is a residual disease or recurrent disease. So second look surgery is always advised when you are operating the patient with canal wall up procedure. So as the risk of recurrence is high, the risk of residual disease is high in canal wall up procedure, most of the surgeons go for second look surgery after 1.5 to 2 years. The problem with this is you have to take the patient to the OT again. So recently there are certain imaging techniques which has been made available. You can avoid the second surgery just to have a second look. So what you can do is you can do something called as diffusion weighted imaging in MRI, which will pick up the recurrent disease early. So that just by imaging you can make out whether there is a cholesteatoma which has recurred or not. So if there is certain signs which say there is a residual disease or recurrent disease, you can take the patient for second surgery. So by then you can avoid the unnecessary surgical intervention for such patients. I think by this we'll conclude today's class. Just I want to mention about the classes. These are the basics you should be knowing, and you will be asked in the exam, so that your viva goes easily. There are much more things regarding the cholesteatoma per se, which will be a class for itself, which I don't want to take this particular class, which will be covered in our classes successively. And other thing is, whatever facts I just told you, is few things are from textbooks and few things which I have learned during residency, and few are also from the conferences and workshops. So that it's a combined material I wanted you people to know. So any queries or any doubts, you can just let us know by chat box so that I can answer. If anything, please let me know. Okay, I have a few questions. I think how to differentiate grade 3 from grade 4 TOS classification by clinical examination. So most of the surgeons, that's the reason they look for the erosion of the scutum, whether there is a minimal scutal erosion, the outer attic wall, whether it is slightly eroded or the erosion is too much. So that you can see the head of the malleus and body of the incus. If they are visible, that means the erosion of the